here we are presenting a PANDA, which is a stand for Pneumonitis Anomaly Detection Using Attention Unit. And let's start. Immunocheckpoint inhibitors, or ICI for short, has revolutionized their immunotherapy. But despite their success, they are often associated with some immuno-related adverse event, or IRAES. Among all of these immuno-related adverse events, pneumonitis is is significant due to its potential for severity. So accurately differentiating of ICI-induced pneumonitis from other pulmonary lung abnormalities or interstitial lung abnormalities is very crucial for patient management. Not only timely and accurate diagnosis of these abnormalities could be very beneficial for medical therapeutic intervention. So here we are proposing a pipeline or workflow to detect pneumonitis from baseline CTs induced by ICIs. So this is the overall workflow of PANDA. From its name, we are referring to pneumonitis anomaly detection. So the approach we choose for this work is based on the anomaly detection. Why we are using that? Because the dataset that we have is very, very imbalanced. Our dataset contains 349 baseline CT, and among all of those 349, only 33 cases has been detected as a pneumonitis. So the approach that we choose to start with is based on the anomaly detection. So we have a 343 baseline CT. We left over we put aside those 33 pneumonitis cases, and then we just start to working with those 309 other lung abnormalities, which could contain lung tumors or pneumonia. So first we crop the lung region, and then do some lung window, and then resample all of our images to some spacing. Then we use an attention unit to reconstruct the images through some convolutional layers and attention layers. Then after that, we have a reconstructed image. If you divide these reconstructed images with the original images, you will have an MSE, which is a stand for mean square error. So if you train a neural network to reduce that amount of MSE, your neural network has already know the latent space of your non-pneumonitis cases. So the idea is this: if I put a new image to our model, the reconstruction error would be much higher than the usual one. So this is the approach that we use. So the idea is this: to train a neural network for your majority classes and put with your MSE distribution. Then after that, if you put new cases to your model, the idea is that the hypothesis is that the error value or MSE value should be higher than the usual cases, the cases that he's trained. So, and also during the training network, we use some harsh augmentation technique, such as outer cutout or mask out techniques are so-called for this augmentation technique, besides to this regular augmentation technique, such as random sampling or flipper left or right, those kind of nominal augmentation. So we compare our results with the other baseline method, such as a clinical model, which is based on the clinical features such as the age, sex, BMI, cough, or smoking history, those kind of clinical features. Also, we compare our model based on the radiomix features, which is extracted from the pneumonitis region. and also we compare the results with the pneumonia with our proposed model. As you can see here, our model managed to get an IUC 82 beat the baseline models. And one thing that I want to mention that here, for the clinical and radiomics model, just like all of the modeling method, you need to put some data for training, testing, and validation. So also you had to shrink your target classes a little bit for training. So imagine that if I have a 33 cases for pneumonitis and I put 60% of this amount for training, so I am left for, I don't know, about 14 cases or 10 cases for the testing. So if I misclassified only 2 of these test cases, my model end up with 80% accuracy. So what I'm gonna say is that your model model performance could significantly change with a 1 case or 2 case misclassification. But in a Panda, that's not a scenario, because we can feed all of the pneumonitis cohort to the model, since the model doesn't need to put aside for a training some of those pneumonitis cohort. And these are the confusion matrix for the clinical, radiomics, and a Panda. Another thing that I want to say is that here, so whenever you want to train a neural network, any kind of a neural network, you have 2 options. First, initialize your weights based on the random values, or usually get some pre-trained weights, such as ImageNet base. But there are some bunch of studies that suggested that maybe it's not a good idea to use the ImageNet weights or any other weights for your clinical usage. So one thing that we do in the Panda also is that we have near 4,000 in-house MD Anderson cases, which contains only CT images. So first, we train our model on those in-house data sets to come up with a good weight initialization. Then we use those weights to fine-tune our model on our pneumonitis cohort. So, and as you can see, our Panda has a very better performance than the other 2 models in detecting pneumonitis from non-pneumonitis, which is the target here. And this is the error distribution of pneumonitis versus non-pneumonitis. There are some challenging cases that our model couldn't differentiate them. This is the clustering line, but for the rest, it's performed well. And these are the ROC curve and precision recall curve, which is one of the famous metric if you are dealing with the imbalanced data set. In both of them, we are managed to get an IUC or area under curve of around 82 and 1. And this is the class distribution for different models and also our grand truths. As you can see, in both radiomics and clinical model failed to, so currently they are doing it's a random guess. So they didn't manage to classify the pneumonitis from non-pneumonitis cases very well, but our Panda somehow managed to differentiate them well. So you may have that question, okay, your model will have a different MSE for the images that doesn't see. Okay, what if I give another image, I don't know, a normal CT scan or even a pneumonia cases? So your model also will gonna generate a different error for that, but are you going to label them as a pneumonitis or not? What you are going to do? So here also we test some pneumonia cases to our model. So our model says that, okay, the error distribution for these cases is not fit in these pneumonitis cases, and also is not fit in the non-pneumonitis cases. It's fitting in something else. So also our model not only managed to cluster these pneumonia cases in a different cohort and not combine it with the pneumonitis cases. And As I mentioned earlier, we need to put some cases for both radiomics and clinical for training. And here's another interesting one, that the cases that you are seeing on the left, so we are feeding this model and we are going to predict that if that patient is going to get pneumonitis in the future or not. This is the whole task. For these images, both our in-house radiologists and model failed to predict if that case is going to develop the pneumonia. But for these cases, the radiologists failed to predict, but our model managed to somehow categorize them as cases that are going to develop pneumonitis in the future. And that's it, my presentation. If you have any question, we have 4 minutes to talk.
Thank you. Any questions? I'll ask a quick question. Those confusion matrices you showed, so if you actually did use the same test set for both, how would those compare?
So based on this table, so you can compare. So from here are the actually a common test cohort on those. So as you can see, also in this cohort, our model has a better performance than the others. Also in the pneumonitis cases, also for this thing we have the radiomics and clinical model failed to classify 2 cases, but our model only 1 case.
So it looks like there are a couple of cases that both Panda and radiomics failed. Did you look to see what was going on in those cases?
Those are one of those challenges cases that even our radiologists, some of like these cases that nothing you can see in the baseline CT that can label it as an anomaly in those CT images.
Any questions from the audience? Yep.
Thank you. That was a very interesting talk. I'll preface this by saying I'm a pulmonologist, so I'm on the clinical side. And so my question is regarding the ground truth, how you guys decided what the ground truth for reference would be, just because sometimes these cases are challenging where a patient will come in with abnormalities, have some degree of heart failure, have an infection, not improving on antibiotics, and then we give steroids. And so it's not totally clear if it's just one issue or whether there's multiple underlying overlapping issues.
Yeah, that's a very good question. The data set that we had was in a follow-up data set. So all of the patients that has been categorized as the pneumonitis has been validated by 3 our in-house radiologists, and using those 5 years of follow-up. And also I think some of them has been go through the pathology confirmation that if those abnormalities that they visualize on the CT is actually pneumonitis or something else.
Okay, in the interest of time, we need to move on. Let's thank the speaker again.
Okay. Thank you so much.
Thank you.